So welcome to this week's Royal College of Pathologists webinar. It's my pleasure to introduce Dr Kathryn Ryan, who is a chemical pathologist based in Belfast, who's just been telling me that at the beginning of the COVID outbreak, she was actually commandeered to go and work on intensive care, which I have tremendous respect for, saying it's about 30 years since I last saw a patient. And fortunately, Nottingham was spared me actually going onto the wards. But Kathryn's going to talk to us tonight about the biochemistry of COVID. So I'll hand over to you if you'd like to take the screen.
Sure, thank you. Thanks, Will. So I'm going to talk a bit about the biochemistry of COVID, really probably the role of the biochemistry lab in the management of patients with this. So when I talk to medical students about the role of laboratory tests in general, we discuss why tests might be requested, and often that is for diagnosis, for screening, for monitoring, and for research purposes. And in patients with COVID, the biochemistry lab, the role is probably really in monitoring of patients. So we're going to talk about some of the tests that are used to monitor patients with COVID-19. And I suppose specifically within that also it's used to stratify the risk of the patient, try and determine how ill or otherwise they are, and give some assessment of prognosis as well. And the reason that's important is that helps us work out perhaps where they are best cared for. So these are two of the hospitals in Belfast where patients with COVID-19 were cared for. So the one on the left is the Mater Hospital, which is where I'm mainly based, and patients who required inpatient care but not ICU care were admitted to there. And then if they required escalated care, critical care, they went to the Belfast City Hospital, which is the building on the right. And it was designated the Nightingale Hospital in Northern Ireland, and was the critical care facility to look after patients there. So along with clinical factors, then laboratory tests have a role in determining where the patient is best cared for. Okay, so these are some of the biochemistry tests that are most useful in patients with COVID-19. We'll not look at all of them. Blood gases are obviously critical in patients with respiratory disease and done at the point of care. We'll look briefly at urea and electrolytes in terms of renal function, and then focus a little more on some of the tests, liver enzymes, inflammatory markers, and troponin. So urea and creatinine used as a marker of kidney function, and patients with any kind of infection have an increased risk of acute kidney injury. So patients admitted with community-acquired pneumonia have an increased risk of kidney injury, whether that's due to factors other than COVID as well. And in studies of patients with COVID from China and Italy, there were rates of acute kidney injury of anywhere between half to 28%. So you can see that in this study from the States that the rate of AKI was actually much higher than that, 37%, a very high incidence of AKI in these patients with COVID. In Seattle, the rate was about 19%. So it was suggested by the authors of this paper that perhaps this was done during a time when hospitals were under acute pressure, and perhaps they were admitting sicker patients than may have been admitted in the other studies, and perhaps that accounted for the very high rate of acute kidney injury. And you can see that the usual risk factors, hypertension, diabetes, cardiovascular disease, apply to these patients in terms of the acute risk. And not surprisingly, it's the sickest patients who tended to get acute kidney injury, and the time at which it occurs seemed to coincide with the time when they would require mechanical ventilation, so at the time when they would have acute respiratory failure as well. In the initial stages of managing COVID in the UK, there was cautious use of IV fluids and a tendency to promote quite a negative fluid balance to reduce the amount of fluid that was present within pulmonary tissue, and that might allow better oxygenation. And I think that probably partly resulted in the higher rate of acute kidney injury, because patients were perhaps more likely to become hypotensive and have poor renal perfusion. As experience was gained, fluid guidance was relaxed, and it'll be interesting to see whether patients managed once more experience had been gained, if there's a lower instance of AKI in them with perhaps a little more relaxed fluid input. It's probably the second most common profile after urea and electrolytes to be requested from biochemistry are liver enzymes. And amongst patients admitted to hospital with COVID, a small number had an increase in bilirubin, but the bilirubin increases weren't probably particularly high. They often had low albumin levels. That's often measured as part of a liver profile, and that's just really when patients get sick, they tend to get low albumin levels. The most striking liver abnormality was increases in transaminases. So AST and ALT tended to be particularly increased in patients with mild disease. Maybe sort of 14 to 16% of them had increases in transaminases, whereas patients who were sicker, maybe up to 2/3 of them had increases in AST and ALT. And it seems that AST was increased more frequently than ALT. AST is less liver specific. It can be released from lots of tissues, and perhaps some of the increase reflects just that there was other organ damage, particularly in patients who were most unwell. The AST levels seem to correlate with the severity of the disease. So in patients who were sicker, whose prognosis was poorer, they had higher AST levels. So this slide just looks at some of the mechanisms by which patients may acquire liver injury, or why the transaminase levels are likely to be increased. So it may be due to direct effects of infection of the SARS-CoV-2 virus. We know that it enters cells via the ACE2 receptors, and in hepatocytes is very low expression of these ACE2 receptors, maybe only about 3%. So it's unlikely that direct infection of hepatocytes would be the cause of increased AST and ALT. Cholangiocytes have a higher level of expression of ACE2 receptors, but if it was due to direct infection of cholangiocytes, you might expect that alkaline phosphatase and gamma GT would be relatively higher than transaminases. So it's probably unlikely that direct infection is the mechanism for that. There are also ACE2 receptors in endothelial cells, so ischemia, perhaps oxidant stress due to endothelial cell infection could have a role in that. May also be due to hypoxia and hypoperfusion as a direct effect of the pulmonary injury due to COVID. And it could be due to the systemic inflammatory response. And I guess we hear a lot about that, particularly in the later course of the disease, when patients have been in hospital about a week, that they can often get very high levels of inflammatory markers. In liver enzymes, there may be or maybe an increase in inflammation leading to apoptosis and necrosis, perhaps cytotoxic T cells causing liver injury and release then of liver enzymes. There could also be an element of drug-induced liver injury, so it's useful to review any medication if a patient has an increase in transaminases or liver enzymes, and things like paracetamol, if they've been given specific antiviral treatment, some antibiotics, hydroxychloroquine, all of those things can cause liver injury and an increase in liver enzymes. Probably one of the other mechanisms relates to pre-existing liver disease. So perhaps up to about 1/4 of the world's population have fatty liver disease, NAFLD, and it's often undiagnosed. And patients with fatty liver, a bit like patients with diabetes, with central obesity, with metabolic syndrome, all tend to have a more severe COVID infection, so perhaps 4 to 6 times more likely to have severe infection. If you have fatty liver disease, you may have existing levels of inflammation in the liver, increased levels of TNF-alpha, and that's perhaps just due to the fatty infiltration. So it may be that then at a time whenever there's increased systemic inflammation, that results in a further increase in liver enzymes and liver cell damage. Hepatitis B doesn't particularly seem to increase the severity of COVID, but fatty liver does. But fulminant liver failure hasn't been seen. So you often get mild increases in liver enzymes. They seem to correlate with disease severity, and the mechanisms causing it are not all completely clear, but there's several possible mechanisms for it, so worth reviewing those in patients when you see liver enzymes, particularly if they're continuing to increase. So one of the major roles of biochemistry tests in COVID is monitoring of inflammatory markers. They're useful to guide prognosis, to stratify risk, perhaps guide resource allocation whenever units are extremely busy. They might have a role in determining who needs hospital admission if it's not entirely clear from clinical factors. They might help to identify a deteriorating patient. And as specific therapies emerge for COVID-19, they may guide when they are needed and when they can be stopped. So these are the major markers of inflammation that have been reported in studies. CRP, which I guess we're probably all familiar with, ferritin, procalcitonin, and interleukin-6. So CRP is very commonly available. It's probably relatively inexpensive to do, and it's produced, or to measure, and it's produced by the liver during inflammation. And it's driven by interleukin-6, so it's an indirect marker, I suppose, of interleukin-6. Ferritin is widely available. It's used as part of an iron profile, but one of the things that limits its use as a marker of iron status is that it increases during inflammation. Procalcitonin is less commonly available, but some labs will do it for specific purposes. We've used it for the assessment of children with symptoms of meningitis. It seems to be more specific for bacterial infection, and the paediatricians have found it useful in maybe determining whether a child has bacterial meningitis or a viral infection. It's produced by the C cells of the thyroid gland, and usually levels are undetectable during health. But if you get severe infection, it's produced by other tissues, so it can be produced by adipocytes and other tissues, and then you get high circulating levels. And it tends to be much higher in severe bacterial infections, or if there is a lot of inflammation present. So it's not absolutely specific for bacterial infection, but it does particularly tend to increase during that. And interleukin-6, which is probably not routinely used as a marker of inflammation in clinical practice, but it is cited in quite a lot of the studies. So what information would be useful from these inflammatory markers? So it might be scientifically interesting to measure them, but like all tests, we want to know if it's going to actually change our management and how it'll impact the care of patients. So does it tell us about disease severity? Do they give ideas about our information about prognosis? Does it tell us if there's secondary infection present and perhaps that antibiotics are required? And as specific treatments emerge, do they guide the use or otherwise of those? This initially looks at CRP, which or the middle panel here looks at CRP as a marker of inflammation in patients with COVID infection. And in this study, it's quite a small study of 27 patients divided into a group who have more severe infection and those who have mild infection. But you can see it quite nicely illustrates that those who present on admission, stage 1 is when they're admitted to hospital, stage 2 is as the disease progresses, 3 is the peak, and 4 is recovery stage, and that's how the authors divided that out. But on admission, you can see that CRP is much higher in the group with more severe illness compared to those with mild disease. And although this is a small study, a lot of the studies looking at CRP would suggest that levels of around 40 or over 40 on admission seem to be associated with severe infection, and levels of less than 20 with milder illness. So it may be useful in stratifying patients on admission as to where they might be best cared for. This one is from patients cared for in Wuhan, again divided into those with mild and severe infection. And you can see that for all 3 markers, so interleukin-6, CRP and procalcitonin, in patients with more mild infection, the levels were statistically different on admission to those with severe infection. I think the limiting factor, the procalcitonin assay that they used here, all of the results, even those for patients with more severe infection, are within the reference range. So that probably limits the clinical utility of that. So while statistically they're different, in clinical practice, none of them went outside the reference range for the assay that they had used there. And again, they quoted that CRPs of less than 20 associated with mild infection, and those over 40 with more severe infection. For interleukin-6, there was a more clear cutoff of around 32, so it seemed a bit more useful than procalcitonin on admission. So perhaps the role for procalcitonin is later in the course of the disease than stratifying on admission. And this slide probably illustrates that it's looking at patients, survivors and non-survivors of COVID-19 infection, and looks at CRP, procalcitonin, interleukin-6. This is lymphocyte count, lactic acid, and then this is the viral count. But probably particularly looking at the inflammatory markers in this. The initial day with a difference indicates the first day on which the levels of the analyte were significantly different between survivors and non-survivors. As you can see, fairly early in the course of the disease, both interleukin-6 and CRP were different between the two groups, whereas procalcitonin, it was around day 20 when it was significantly different between those who survived and those who did not. And it might be that at that point it is perhaps reflecting overwhelming inflammation or perhaps secondary bacterial infection, and if it could be demonstrated that that was the case, then it's likely that that will be very useful in clinical management, perhaps in terms of when antibiotics were required and prescribed, but probably a bit more information is needed to determine that. So this one looks at as comparing interleukin-6 and serum ferritin, and again this is between survivors and non-survivors, and I guess I show this because the clinicians in our trust felt that serum ferritin was useful for patients in intensive care, and it was measured usually 3 times a week, sort of on alternate days. We'd measure ferritin to see if that would track the progress of patients. You'll know that patients with COVID often have prolonged ICU stays with relapses and then stabilising clinically, and the ferritin they felt seemed to reflect that. You can see that patients who did not survive had higher levels of both interleukin-6 and ferritin, but there's an overlap in the values between the two groups, between the survivors and non-survivors. So particularly on admission, it may not necessarily stratify for individual patients who is high risk and who is not. And you can see, I suppose, in keeping again with what we know about the disease, is that this increase in inflammation in patients who have more prolonged illness. So from day 10 onwards, increasing levels of both ferritin and interleukin-6 associated with that inflammatory response. So we know that inflammatory markers are increased in COVID. CRP seems to be useful in determining patients who are most ill at presentation. Procalcitonin may potentially have a role in determining or indicating if patients have developed secondary bacterial infection. And interleukin-6 perhaps doesn't offer much more information at present than markers which are easily available to us. There may be a specific role for ferritin, and in a small number of patients, the level of inflammation gives a clinical picture which is similar to HLH, to secondary HLH. So secondary HLH usually occurs or can occur secondary to things like graft versus host disease, but also secondary to viral infection. And it's a really overwhelming inflammatory response where you get very high levels of cytokines, you get organ failure, very high temperatures, low counts of one or more blood cell lines, extremely high ferritin levels, high triglycerides, and there may be pulmonary involvement in it. And it suggested that there may be a COVID-specific form of this. So in some of the literature, it's described as the COVID cytokine storm syndrome, although that's not clearly described. So HLH, there's specific criteria, a scoring system for determining if a patient has that. And that's been applied to some patients with COVID. And if you have HLH, there's immunosuppression is often useful in managing that and improving survival of that. And that may be the case with COVID. So I think that's why ferritin is interesting, because it may flag up patients with this really severe, overwhelming inflammation and the cytokine storm syndrome. So that may be the role or the place where it is most useful in determining that in the patients, the cohort of patients who are most unwell. So there's been considerable discussion about cardiac disease and COVID, and we know that patients with cardiac disease are at increased risk of severe COVID infection. We also know that patients with hypertension and diabetes and risk factors for cardiovascular disease are also at increased risk of COVID, and there's associated cardiovascular mortality associated with it. Any respiratory disease can be associated with increased cardiovascular mortality. So patients admitted with community-acquired pneumonia are at increased risk of an adverse cardiovascular outcome. Flu infection can be associated with MI, with myocarditis, and other coronavirus epidemics, so things like SARS and MERS, can be associated with arrhythmias, with tachycardia, with bradycardia, with cardiac arrest, and also with heart failure. So I guess SARS-CoV-2 is not unique in having an adverse effect in terms of cardiovascular outcomes. And it may be that some of the patients are those who are known to have cardiovascular disease and are therefore at risk of them. And in some of them, the cardiovascular complications arise in patients who did not have any previous known vascular disease. And one of the key indicators of cardiac muscle disease is increased troponin. And this slide looks at the various reasons why it may be increased in patients who present with COVID. So troponin assays that we use, troponin I and troponin T, are cardiac muscle specific, but they're not specific for ischemia. So they're specific for cardiac muscle damage, but we have tended to use them in the situation of acute coronary syndromes where we're suspecting patients have acute ischemic heart disease. Some patients will have chronically increased levels of troponin, and so the change in troponin level is the key thing. So just like when patients present with acute coronary syndrome, and we usually measure a couple of troponin levels and look for the change in that, the same applies here. So you get an elevated troponin level, it's useful to see is there a baseline one or to measure a second level. So it may be that patients with things like chronic kidney disease or who are known to have heart failure will have a baseline troponin that is high, and there may not be any change in that or anything to indicate that there has been an acute event. Then on the other side of that, there are patients in whom the elevated troponin will indicate an acute myocardial infarction. For some patients, that will be similar to the usual presentation with an acute coronary syndrome. It'll be due to plaque rupture, plaque instability, and clot formation. And we know that patients with severe COVID-19 infection are in a hypercoagulable state, and so that might put them at increased risk for that. In some patients, it may be that they have a compromised coronary circulation, and then when there is hypoxia due to their respiratory disease or hypotension, that causes an acute ischemic event. In others, it's not an ischemic injury, so it may be due to direct viral infection or myocarditis secondary to the SARS-CoV-2. And in others, when there is overwhelming inflammation, that perhaps the level of inflammation causes cardiac muscle damage. And as we mentioned, patients are in a hypercoagulable state, so there's an increased risk of pulmonary embolism as well due to that. So there's lots of reasons why troponin may be elevated. And I guess the difficulty is that sometimes the additional investigations that we would do are more difficult because of infection control measures. So it's a little more difficult perhaps to take someone for angiography than what it might be when there's not an epidemic of an infectious disease. So we look at the troponin, we look at the other risk factors that the patient might have. Bedside echo is useful, and I guess intensivists are used to doing bedside echoes and looking at cardiac contractility and seeing does it look like myocarditis or cardiac failure, or does it look like there's an acute ischemic event. But the clinical picture, ECG and echo findings should be carefully reviewed, and in some patients it may be that catheterization and PCI is the most appropriate management, but it can be difficult to work out what the right course of action can be in these patients. In all of them, the high troponin level is associated with mortality. So a bit like the inflammatory markers, a high troponin is a poor prognostic indicator, as are increased levels of the liver enzymes too. The patients who do worst are those who we know have cardiovascular disease and get a high troponin level. But even if you don't have known cardiovascular disease and the troponin level increases, that's associated with increased mortality as well. And as you can see, I suppose a bit like the inflammation occurring after kind of a week to 10 days, troponin levels tend to increase at around kind of 10 to 16 days is whenever the cardiac complications are most likely to occur. And the other cardiac marker that is sometimes measured and is mentioned in some of the studies looking at patients with COVID is BNP or pro-BNP. And it, a bit like troponin, is associated with increased mortality, with some of the cardiovascular complications of the disease, and tends to increase in the sickest patients. Okay, so that's a bit of a tour through the role of the biochemistry lab, the reasons that we get these tests sent to us in patients with COVID, and some of the reasons that we get increased levels of some of these biochemical markers. So none of the tests, as we said at the outset, are COVID specific. So we're not like virology who have, I guess, the kind of diagnostic tests. But there's a kind of classic constellation of abnormalities that we see in patients who are admitted to hospital with COVID-19. So some of the tests may be used to guide whether a patient needs admitted. Then we could be used to stratify the risk and so help, particularly at times when resources are more limited. They may guide specific treatments as they emerge. They may indicate recovery, or it will be useful if they indicated there was secondary infection. They may indicate if there are complications, so things like troponin increasing, looking for cardiovascular disease, and they could increase or indicate the presence of overwhelming sepsis and potentially this COVID cytokine storm syndrome that could potentially be another life-threatening complication of COVID infection.
Fantastic. Many thanks, Kathryn, for taking us through all the different systems. I think if there's one thing we've learned in these webinars, it's that COVID is really a multi-system disease and affects all the different organ systems. So I have a number of questions. I think before I get stuck into what you've actually told us, I've got a couple of questions relating to things you haven't told us.
That's making me nervous.
The first question is there any evidence of a paraproteinemia, paraprotein production? Apparently there are some case reports. Is there any study in the UK of paraprotein estimation in COVID infection?
Not that I have come across to date on that, but I suppose if you get increased levels of inflammation, that might be feasible, but not that I'm aware of.
Okay. And another topic that comes up week after week is whether or not there is a post-COVID syndrome, particularly fatigue. And the question is there any marker of that you've noticed in, I don't know if you've been following your patients as outpatients, fatigue, and is there any way of monitoring that?
I don't think that there is any, because it tends to be things like the inflammatory markers do tend to settle and the troponin levels do tend to improve. So I don't think that there is currently any biochemical marker that we measure that would be in keeping with that. But I think there's quite a lot of interest currently, I suppose, in the kind of post-COVID syndrome and whether there's kind of long-term lung and cardiac damage is associated with it too, but no, I'm not aware of any markers specifically used for that. Okay,
so you started with the kidney, and there's quite an alarming rate of acute kidney injury. Yeah. Does that lead to dialysis or not?
Yeah, so for some patients it does, and I think initially quite high rates of dialysis, and I think that was partly then why I think the UK intensivists would have had calls several times a week, kind of sharing, learning as they kind of manage these patients. And I think that was one of the reasons for perhaps not running patients quite so dry, was because a lot of patients were ending up in dialysis, and that was obviously going to be tricky in terms of resources. We had a lot of patients in intensive care requiring dialysis. So we certainly had a few patients in Belfast who needed it, some of them who required it temporarily, and some who on discharge to the ward continued to require it. But yeah, there would have been patients who needed it, I think, more at the start because of the restricted fluid as well.
So the pathogenesis, is it just fluid imbalance that's damaging the kidneys?
I think that's probably a large part of it. Some of it may be that when we give things like vasopressors, maybe that affects renal function. I guess these patients are often hypotensive. If you get a cardiac insult as well and drop your blood pressure with that and hypoperfuse your kidneys, that also causes a problem. I guess the could potentially be, I suppose, direct infection of endothelial cells within the kidney too. But I think a lot of it probably relates to when patients get signs of sepsis or hypoperfusion or shock as well, that they're more likely to get it. So it's the sicker patients, the patients who drop their blood pressure, who get the cardiac problems, who also get acute kidney injury as well.
Okay. Then you talked about the liver, and again, an alarming rate of raised transaminases. How high are we talking? Just sort of less than 100?
Yeah, I think they're milder. So a lot of patients will have slight increases, often at less than 100. Some patients will get higher levels than that. But I suppose I kind of think it's interesting, I suppose somebody who works with patients who often have the metabolic syndrome, like diabetes and dyslipidemia, who often have a high level. It would be more like the milder increases you see in those patients. And I suppose I'm interested in the fact that patients with fatty liver disease are at increased risk, that kind of whole metabolic syndrome type thing. But no, it doesn't seem to be that there are huge increases in most patients in liver enzymes. I think if there were big increases, then you might look at the medication, the drugs, you would look for potentially another cause. Low level increases you'd probably put down to the COVID itself.
And the inflammatory markers. So there are lots of these. I've basically had a couple of questions, asking what's best, and what can you measure early on that's predictive of who's going to end up in intensive care, which is what you really want to know.
Yeah.
And is there any kind of scoring system or algorithm to combine all the different inflammatory markers?
I don't think there's any established kind of system yet for that, but that I think is something that will probably emerge as we kind of review our databases of all the information that we've kind of gathered over the last few months. I think CRP, and I suppose from reading in preparation as well for this, is still useful. I think if you saw a patient who had a CRP of over 40, you would be thinking that they were at higher risk of deterioration. So I think it's easily available. We're familiar with the reference ranges for it. Interleukin-6, I guess, does seem to help stratify patients, but we're less familiar with it. So perhaps, and it's likely to be much more expensive to measure.
Were you measuring IL-6? Because we looked at our Nottingham patients, and I was told by clinical chemistry they were doing an IL-6 test, but when we looked, barely any of them had it been requested.
Yeah, no, we didn't measure it at all. No, we used ferritin, we used CRP, we'd have measured troponin, but not IL-6 in any patients. I think the ferritin probably is useful because, particularly for patients in intensive care, the sickest patients, in case you do see that kind of overwhelming cytokine storm, and it does seem to track, so that if the ferritin goes up, that's a patient that you might monitor a little more closely. You might think you're going to have to prone that patient. It seemed to track quite well with the disease. So perhaps not at admission, but during the course of the illness, I think it kind of gives you a bit of a heads up on who's sick and who's improving.
And D-dimers is another one we thought we'd look at, and then discovered that it had hardly ever been measured. Yeah,
our haematologists were quite keen that we did measure that, and it was done, but I'm not sure that we did a lot with the results. So it was measured in intensive care patients, but not on our ward patients, so the kind of smaller, sicker cohort of patients. But I don't think we probably did much with that. Either I think it tends to be higher again in sicker patients in some studies, which suggest that it's again a bit like CRP and other inflammatory markers, a prognostic indicator.
Right. I've had a comment here that somebody, Pritchard et al., have reviewed prognostic scores using an international data set of about 40,000 patients, and that's under analysis. So I guess we just have to wait.
Okay, there'll be something coming from that, yeah.
Yeah. The procalcitonin then, as an indicator of bacterial infection, how common is superinfection in COVID patients? I mean, I've been a bit surprised that it's not that common.
Yeah, I was reading as there was a review which suggested that there'd been relatively little published about kind of secondary infection in it, and suggesting that perhaps we weren't looking for it when maybe we should be, that it would be likely, I suppose, in the way that patients with influenza get secondary bacterial infection, and patients with, I think they cited that patients with COPD were at increased risk of severe COVID, and were also likely to have kind of underlying bacterial infection that might emerge if they were ill. We didn't measure procalcitonin. We kind of asked our clinicians, was that something they wanted, and it wasn't. I know we kind of used it in other settings, as I mentioned, looking at children with meningitis. It does look like it increases perhaps later in the course of the disease, but I can't find anything that correlates that with secondary bacterial infection. I think that's something we maybe don't know enough about, but that I think might be a potential use for it. If it did correlate with that would be really, really helpful to know. But I don't think there's anything conclusive on that at the moment. Okay.
And then secondary HLH, which I'm not going to attempt to pronounce. So to me, that rings bells of Epstein-Barr virus infection.
Yes, that's right. Yeah.
Is there any suggestion that that's reactivating and maybe contributing to that?
I hadn't thought of that. Anything I've read about it, I suppose, does mention Epstein-Barr as a common kind of precipitant of it, but I haven't seen anything linking it with reemergence of that. But I guess that could potentially be a mechanism for it.
Yeah, I mean, I have to say, nobody's asked us to look for EBV viral loads in all these patients, but maybe that's a study waiting to be done. Yeah, so then the myocarditis. So someone has said that there is no histological evidence of myocarditis in the post-mortem studies, and indeed no histological evidence of myocarditis or ischemia. So what else might be the cause of the large troponin rises?
I'm not sure. I guess I kind of wondered, does the inflammation have an effect on that? I don't know what else is the cause, because I guess troponin is cardiac muscle specific, but any kind of cardiac muscle could cause increases in it. I guess they'll not all be patients, there'll be a few patients in whom it'll be things like a pulmonary embolus. Patients do certainly get poor myocardial contractility, that some of the patients in intensive care will drop their blood pressure, and an echo will indicate that the paraventricular function. So I guess I don't know if that is associated with heart failure, or whether it relates to the inflammation that causes some kind of muscle damage as well. I'm not sure beyond that. I think some of the patients probably do get or potentially get ischemic damage. There's certainly in theory mechanisms by which they might get that, and I suppose that there are a population who are at risk from that, if it's more common in patients with diabetes and underlying cardiovascular disease as well.
Right. So there's been a few questions that have come in whilst I've been asking questions. So have there been any studies regarding the joint affection and laboratory tests in patients with post-COVID fatigue? But we've already had that.
I don't think there are, yeah.
Joint problems, is that?
I haven't seen anything specifically on that, or
bone pains.
Yeah.
Yeah.
Not aware of anything specifically related to that.
I'd like to know if any immunoglobulin levels are checked to know do immunoglobulin levels change as the patient is seroconverting?
I don't know the answer to that. I guess it wasn't something that we have serially measured, and I haven't seen any data published on that, but that may be something that there is information on, but I'm not aware of that. Yeah.
We'll ask Alex Richter next week.
Yeah.
And yes, that's an interesting one. Is there a marker that helps you decide whether or not dexamethasone treatments should be used?
There was the bigger study looking at dexamethasone. I couldn't see anything about markers in it. There was one study that looked at CRP, and not a specific cutoff, but just showing that you got falls in CRP with dexamethasone treatment, and as the patients improve. But I do kind of wonder if some of the inflammatory markers may be useful in kind of perhaps as a part of a scoring system to determine when treatments like that might be useful, and then when they could be stopped. Okay,
the myocarditis discussion. This isn't really fair to ask you this one, but has there been demonstration of viral particles in the myocardium? Presence of virus has been demonstrated in peripheral skeletal muscle by the Johns Hopkins group. As I remember from last week, if it was last week, when we had a histopathologist telling us about postmortems, there was a distinct absence of proving virus anywhere, and I got the impression that they were still working out how best to do immunochemistry or some very fancy genome amplification tests.
Okay.
But there is a question: anything on CK and skeletal muscle?
You do get increases in CK with it, so I'm not quite sure what the mechanism for that is either, but that's another marker that's measured in biochemistry that we would sometimes see increases in. I guess it's not something that have been used to guide prognosis or admission, but some patients do seem to get rises in CK, and I'm not sure why that would, what the mechanism for that is either.
Right. We're coming to the end of the time, and oh gosh, still more questions coming in. All right, not questions. So I think I've asked all the questions that have been posted. But there's one comment that I've left to the end just because it might be of interest to people. I won't mention who it's from because I'm not sure if she wants me to reveal that. But there is someone in the audience who's doing a study of cytokines in post-viral fatigue. So it's possible if some of you are interested in that, either because you are suffering from post-viral fatigue or you're just interested in helping out with that research, then I'm sure we can put you in touch. So with that, it just remains for me to say a very big thank you again for a very broad overview. You've covered an awful lot of data, a lot of primary publications, and it's been a really interesting discussion. So thank you very much for joining us. For the rest of you, thank you very much for all your questions, as ever, very stimulating. Just to remind you, next week is immunology. If you want to join us for that, then do re-register. And with that, I will say have a good evening. Thank you very much.